Today we are breaking down a high-yield, life-threatening condition, hemophagocytic lymphohistiocytosis, or HLH. This is a favorite topic for examiners because it integrates immunology, pathology, and critical care. Let's start with a classic clinical vignette. Look at the case presentation. We have a 5-month-old infant presenting with a 1-week history of high fever, irritability, and a rash. The physical exam shows an ill-appearing child with marked hepatosplenomegaly. But look at the labs. This is where the diagnosis hides. We see severe pancytopenia, that's thrombocytopenia, anemia, and neutropenia. There is hypertriglyceridemia, and importantly, a massive ferritin elevation to 12,000 nanograms per milliliter. The bone marrow biopsy shows macrophages actually engulfing erythrocytes. Now, the question asks, what is the underlying pathophysiology? Is it A, impaired respiratory burst, B, uncontrolled activation of T cells and macrophages, C, autoantibody destruction, or D, massive ion release from cell lysis? The correct answer is B, uncontrolled activation of T lymphocytes and macrophages due to defective cytotoxicity. Let's define this condition. HLH is a syndrome of massive, uncontrolled hyperinflammation, a cytokine storm. The core failure here is that the immune system can initiate a response effectively, but it fails to terminate it. Think of it as the immune system losing its brakes. Mechanism, the normal versus the failure. To understand this, we need to look at the cellular mechanism. Normally, when a CD8+ cytotoxic T cell recognizes a virus-infected cell, it forms an immunological synapse. It releases cytotoxic granules containing perforin, which punches holes, and granzymes, which induce apoptosis. Once the target is dead, the antigen is cleared and inflammation subsides. But in familial HLH, this is broken. The recognition happens, the synapse forms, but the weapon fails. Key genetic mutations to remember for your exam are PRF1, coding for perforin, and UNC13D, involved in vesicle docking. Because the target cell doesn't die, the antigen persists. This creates a vicious cycle of continuous synapse formation and uncontrolled proliferation of T cells and macrophages. This results in a cytokine storm. The pivotal mediator here is interferon gamma, along with IL-1, IL-6, and TNF-alpha. This storm drives macrophages to become hyperactivated and start eating your own blood cells, that is, hemophagocytosis, which explains the severe pancytopenia we saw in the patient. Classification and the threshold model. We classify HLH into 2 types. Primary HLH is genetic or familial. It follows Mendelian inheritance, autosomal recessive, and typically presents in infancy, just like our 5-month-old patient. Secondary HLH is acquired and usually triggered by something else. The top 3 triggers are infection, specifically viral, with Epstein-Barr virus being the number 1 trigger, malignancy, often T or NK cell lymphomas, and autoimmune, known as macrophage activation syndrome. Think of the threshold model. A patient might have some background inflammation or heterozygous genetic mutations. When you add a trigger like EBV, the immune activation breaches the critical line, resulting in uncontrolled inflammation. Related high-yield disorder. A quick side note for the exam. Chediak-Higashi syndrome. This involves a mutation in the LIST gene, lysosomal trafficking regulator. Clinically, look for partial albinism plus susceptibility to HLH. The hallmark on the peripheral smear is giant cytoplasmic granules in neutrophils. Diagnostic criteria, HLH 2004. How do we diagnose HLH? You need a molecular diagnosis or 5 of these 8 criteria. 1. Fever. 2. Splenomegaly. 3. Cytopenias, affecting at least 2 lineages. 4. Hypertriglyceridemia or hypofibrinogenemia. 5. Hemophagocytosis in the marrow or spleen. low or absent NK cell activity, ferritin greater than 500 micrograms per liter, soluble CD25 elevation, which is the IL-2 receptor. Let's focus on ferritin. While the criteria say greater than 500, levels greater than 10,000 nanograms per liter are over 90% specific for HLH in children. Extreme hyperferritinemia in a febrile infant is a red flag that demands an immediate workup. Distractor analysis. Why not the others? Briefly, let's rule out the other options from our question so you don't get trapped. Option A was chronic granulomatous disease, CGD. This is a defect in NADPH oxidase, impaired respiratory burst. These patients get recurrent abscesses with catalase plus organisms, like Staph aureus or Aspergillus. They do not present with this massive systemic cytokine storm. Option C was autoimmunity. Conditions like ITP or Felty syndrome involve antibody-mediated destruction. While autoimmune diseases can trigger secondary HLH, MAS, the primary driver of HLH is T-cell macrophage activation, not just antibodies. Option D was tumor lysis syndrome. This is metabolic chaos, hyperkalemia, hyperphosphatemia, and hyperuricemia. It usually follows chemo and doesn't present with the classic fever, splenomegaly, and hemophagocytosis triad. Management strategy. Treating HLH is a race against time. We have two phases. Phase 1 is suppression. We have to stop the storm. The key drug is etoposide, which selectively depletes activated T cells, combined with dexamethasone, which crosses the blood-brain barrier. We can also use targeted therapy like emapalumab, an anti-interferon gamma antibody. Phase 2 is the cure. For primary HLH, suppression is only temporary. The genetic defect must be fixed. The only curative therapy is allogeneic hematopoietic stem cell transplantation, or HSCT. This replaces the defective immune system with functional cytotoxic machinery. Special context, macrophage activation syndrome. Finally, keep in mind macrophage activation syndrome. This is simply secondary HLH occurring in the context of autoimmune diseases like systemic juvenile idiopathic arthritis, or SLE, lupus. It is often treated with steroids and IL-1 blockade, anakinra, reserving etoposide for severe cases. Summary and exam essentials. To wrap up, here's your exam summary. Pathophysiology, defective cytotoxicity leading to a cytokine storm driven by interferon gamma. Key genetics, PRF1, perforin, and UNC13D. Key diagnostic triad, fever plus splenomegaly plus cytopenias. Key lab, ferritin greater than 10,000 nanograms per liter. Clinical pearl, HLH is the sepsis mimic. Patients look septic, but cultures are sterile. Remember, early suspicion saves lives.